Okay, in our last section on evidence-based therapy, we're going to use a case as an example to show you how one might apply the various principles that we've discussed. And that case will be of Alaska, and then once we're done with that, we'll summarize the general concept of evidence-based therapy. So before we head off and talk about Alaska, what I'd like to say is that this concept of this approach of using the various acronyms, PAC-MAN, the concepts of evidence-based therapy, these are ideals. Okay? There are going to be situations where you're going to say, well, I don't have time to do this, or I don't think I need to do this because I've seen cases like this before. And I think the most important thing to think about in that regard is what do you need to do if your first treatment or your first approach is not working. If plan A is not working, you need to step back, and you probably do need to take a more detailed approach to therapy and look at the literature more carefully. But we're going to assume that you're a neophyte to all of this. You're taking a boot camp in pharmacology, and we're going to show you step by step how you can approach therapy, how you can find literature about therapy, and how you can apply it to the specifics of a case. And our case is Alaska. She's a 4-year-old Labrador Retriever, 30 kilograms, and she has a fairly basic problem of severe pruritus. And the diagnosis followed a skin test, so we're going to presume a diagnosis of atopy, which is an allergic condition, in her case, to multiple allergens. So there's not, so we have to keep that in mind. She's allergic to multiple things. She's an allergic dog. So let's look at the relevant clinical questions, and this is our step number 1 we talked about before. So what is the most effective treatment of for chronic pruritus due to atopy? And then we want to ask the question, what's the appropriate dosage of this drug therapy, if we're going to use drug therapy? What side effects? And is any prophylactic therapy rational to avoid adverse effects? So these are questions that are relevant to her case. They're going to help us manage her case more effectively. We're not going off on to wild tangents and asking questions that might be interesting but not relevant to managing her case. That's the point. Okay, now with these questions in mind, we're going to try to find the best evidence to answer the question. And what we've told you is that you're going to have access to an online, very good online formulary called Veterinary Drug Handbook. And so formulary is going to be one option that we can use. And we'll talk about the good aspects of a formulary in this particular one, and what you have to keep in mind about the limits of such a source of information. You can realize, so we'll just start out by saying that a formulary is what we consider to be either a secondary or tertiary type of source, meaning that it's it's often derived from book chapters or review papers, and occasionally you get to some primary literature. And I think getting the closest you can to the primary source of information will help you make a decision about the relevance of that information to your particular patient. But a formulary is going to have digested a lot of this for you, and so that's great. So we have other sources of information that we can draw upon, of course, doing a Medline search, and you want to include those that have veterinary journals because you have veterinary patients, or you can look at sources like Veterinary Information Network, and I always have to remind students that Veterinary Information Network itself has opinion. There's an opinion of specialists in there. There's literature-based abstracts. There's a variety of sources, so you have to keep in mind that you're going to get a variety of different things from that. And so let's go through what's in VIN as an example. Abstracts of veterinary journals, abstracts of non-veterinary journals, so this gets down on the relevance from the standpoint of species. Formulators there as well, and conference proceedings. These are specialists going out. It might be a little bit more up to date about a certain topic, but you have to keep in mind there's the bias of a specific person giving that talk. And of course, the case discussions, first of all, you have to believe that the case information is being provided is correct, and then the discussion of the specialist is going to reflect their bias as well, but it's going to get you closer to a lot of the maybe cutting edge types of therapies that you might want to find out about. Okay, now let's take a look at our Pac-Man. Our first two parts of Pac-Man are what's Alaska's problem? Well, we already stated that, allergy and atopy. So that's where we start, the P. The approach, well, we're not going to do surgery, we might be using a palliative treatment, but this is a medical treatment. Management will also be part of it, because we may want to reduce the burden of whatever antigens she might be allergic to. It could be dust, it could be fleas, it could be a number of things. So the approach is medical, the problem is atopy or allergy. Okay, so we do a literature search and we find a number of papers that can help us get to the question of what's the most effective treatment for an animal with atopy or an allergic condition. And I'm going to point out some things about each of these papers as we go along and sort of mark it up. So the first one is you got to look at the journal and the date. So veterinary medicine. So generally this is a review type paper. It's a 1988 paper. So we're now 22 years, from that. Excuse me, more than that, 32. And so you have to keep in mind, not that treating atopy has changed all that much. There are new therapeutic options. There are new therapeutic options we have to consider. So if you read that paper, keep that in mind. Then you have one in 2010, a systematic review, and I'll go ahead and tell you that Oliveri is a veterinary dermatologist at NC State. And so remember I told you, systematic review is looking at a bunch of papers, a lot of randomized controlled trials that are out in the literature, and summarizing key aspects of those. And so this is the highest level of information that we can find for a particular treatment. And this dog has atopic dermatitis, so we're going to say, let's keep our eyes on this. What's the downside? It's now a 10-year-old paper. Then we have another systematic review and meta-analysis of the efficacy and safety of cyclosporin, one specific drug, for treatment of atopic dermatitis. This paper is now 14 years old, but we'll just kind of put that out there as at least telling us about cyclosporin if you want to go down that route. And then we have the next, number 4, all the keywords, all the magical words: randomized, double-blinded, placebo-controlled, multi-center. Why is multi-center interesting? Because then you might have something that applies to you down in Georgia, but then a study that's done up in Maine may not have the same sort of background, fleas, or may have the background other antigens. So having a multi-center study does give you that flavor, usually, of geographical differences, and also a larger number of cases. So what is this study? This study is a dietary intervention of diets that have high levels of eicosapentaenoic acid and gamma-linolenic acid. And then we're back to another systematic review of 2003, again, Oliveri, the pharmacotherapy, that's what we're about here, of canine atopic dermatitis. So, and this is in the Journal of Veterinary Dermatology, so that's probably a pretty good one too. If you want to go dietary therapy, this would be good. And then finally, a study of 1989 for a specific drug class, antihistaminic drugs, that's in DACVMA, which is a good journal, but this paper is 31 years old. So these papers will help us sort out if we have to go all the way back to, if we're already on plan B and we need to find out what are the specialists saying nowadays. Well, what's the newest one we have here? That would be this one. And if we decide we want to try something conservative with diet, we might want to look at this one, etc. Okay, to go back to critical appraisal of the evidence at step 3, let's look at some of these 3 main types of references. Medline, the issue there is that you have to be careful to look for veterinary journals, and it may leave out some key veterinary specific material, so you have to be careful about that. You, on the other hand, could find mostly peer-reviewed primary manuscripts and review papers, and you'll find out something more about basic drug mechanisms. Veterinary Information Network, it's a conglomerating source that includes veterinary journals, abstracts, and commentary. We already talked about that. And then you've got Dr. Google. And we all know Dr. Google is going to be brought in part by your clients. So you have to be very careful when you just do a Google search that you are trying to apply these critical principles that we're talking about. Okay, let's now dig into some of the papers that we said would be good ones to take a look at. And the first one was that systematic review of randomized controlled trials by the dermatologist Oliveri. And this is the newest one that we found, which is 2010. We might do better than that now. I'm not sure if we would or not. But so the evidence to decrease pruritus or skin lesions in these studies, and these combination of studies, they found that tacrolimus showed 3 randomized controlled trials that did that. The glucocorticoid triamcinolone, 1 randomized controlled trial. Oral glucocorticoid, so we can kind of lump these 2 together, 5 randomized controlled trials. Cyclosporin, 6 RCTs. And then you get into additional therapies that are impacting the immune system, gamma interferon 1 trial, and subcutaneous allergy-specific immunotherapy as a strategy to try to desensitize the animal, 3 trials. And then there was 1 high-quality trial that showed that if you added essential fatty acids, you could reduce the glucocorticoid use by about a half. So that's something we all want to keep in mind. But these are from this systematic review. Now going to Stefan's review, a little bit older, but also a systematic review. And this gives you a good idea of what you get out of this. We have 10 studies that are being reviewed here. Combine almost 800 dogs, and then what they're doing is they're looking at the drugs that are being used, and they're finding many were treated with cyclosporin, only 20% had a placebo, surprisingly less than 10% were treated with oral glucocorticoids, and less than that antihistamines. And so the treatment duration ranged from 2 weeks to 6 months. Let's get now to the study of the diet, a randomized, double-blinded study, placebo-controlled, multi-center study looking at the effect of the fatty acids, eicosapentaenoic acid and gamma-linolenic acid. And what they found were that in these studies that were reviewed, they had 13 dogs receive standard diet and 15 received a high a diet high in these fatty acids. And so their conclusions were that, as I said before, that a diet with these that are high in these fatty acids is effective in reducing pruritus and erythema in dogs with atopic dermatitis, but not all dogs responded. Not all dogs. So that's something to keep in mind, something the owner might want to do to change the diet of the animal, but they have to be told that there's a chance it may not work. Okay, now our fourth step is to apply the information, integrating what we can do as a clinician and the circumstances of the patient and the owners. And so looking at the data, we decided that basically the effect of antihistamines, and this has been known for some time, in dogs is limited. Why is that? Well, because antihistaminic compounds are receptor antagonists. They don't achieve really high concentrations at the sites of pruritus subcutaneously. And so, but they have fewer side effects than many of the other drugs like glucocorticoids and cyclosporin and the immunosuppressants, and they're less expensive. So you have those two sides of it. Cyclosporin and tacrolimus are expensive. We'll talk about their mechanisms, but we might want to use those later. So the owner, after being presented with the options, sort of liked the idea of starting cheap with glucocorticoids. This is not uncommon with a dog like this, and then trying the dietary supplement and adding that possibly later if necessary. So we started very simply at the beginning with glucocorticoids and said they were ready to go with the more expensive diet later on. Okay, so with each drug class, we can talk about Pac-Man. And so we're now getting into classes of drugs. So we know the problem, we know the approach, medical, atopy, and the class of drugs here is an H1 receptor antagonist. We call it antihistamine. Mechanism of action, well, it blocks histamine 1 receptors, and histamine is an important mediator, not the only mediator of allergy, but it's an important mediator that's released when IgE stimulates mast cells to degranulate. And so when this histamine comes out, it leads to effects that leads to redness, leads to possibly a very severe reaction, can lead to hypotension, etc. Now, the second class of drugs we might want to consider are, we'll lump them together because they are the similar mechanism of action, cyclosporin and tacrolimus. And this mechanism of action is that since these drugs impact T lymphocytes and a little bit of T suppressor cells as well. So lymphocyte production and release, including interleukin-2, from primary T helper cells are inhibited. So basically these are inhibiting both cell-mediated and humoral immunity. That means immunity from the immunoglobulins, if you will, the B cells. And this tells you that this is a very broad type of immune suppression and should tell you that you also open up the animal to side effects of other infectious diseases. So understanding the mechanism help you project to or predict some of the adverse effects. Now the other class of drugs we talked about were the glucocorticoids, and these are synthetic glucocorticoids, either triamcinolone or in this case possibly prednisolone or prednisone. They're all related, and we'll talk about that within the context of the course. But their mechanism of action is that they interact with the nuclear receptor, and then they induce a protein called lipocortin that then suppresses the release of the fatty acid or arachidonic acid, which leads to bioactive mediators, leukotrienes, and prostaglandins. And these lead to recruitment of inflammatory cells. Glucocorticoids are known mainly to impact cell-mediated immunity. but they're known for not only their issues with regards to exacerbating other types of infectious diseases, but they also can have metabolic effects, as we'll get to next. So the issue with glucocorticoids that one has to be concerned with is that they have a sort of a triumvirate of effects. Two that we might be looking for: anti-inflammatory effect in this case, and in the case of also immune suppression. Those two effects overlap, of course, but they also are hormones. And they're hormones made by the adrenal gland. And so when we give these drugs, they also have side effects that can impact the endogenous rhythms of the adrenal, hypothalamic pituitary adrenal axis. So this tells us a little bit, by knowing the mechanism, by knowing the class of drugs, we can predict what might be happening with regards to side effects of a drug class like glucocorticoids. So why are they so potently used for something like an allergic condition? And this graphic basically is centered around the phospholipase A2, which is that enzyme that produces arachidonic acid. It's that initial fatty acid released from the plasma membrane that normally feeds into two pathways. One is the cyclooxygenase pathway that leads to thromboxanes, prostaglandins, prostacyclin. And the other one, and so let's just start with these. These are the types of drugs that are very engaged in inflammation. Let me write that down. So we're talking about inflammation here, at least with regards to mediators of inflammation. But on the other side, these arachidonic acid can pass in through the lipoxygenase pathway to produce leukotrienes and other chemotactic lipids, and these will impact the cell-mediated immunity. So they're attracting cells that are associated with inflammation. Lymphocytes, eosinophils, etc., macrophages. And so because glucocorticoids impact very proximally to this whole process right here, by reducing or blocking this phospholipase, they will impact both inflammation and cell-mediated immunity. Whereas if you just gave the animal, as we'll talk about, NSAIDs or non-steroidal anti-inflammatory drugs like aspirin, they only block this enzyme, and so you're mainly seeing benefit of reduced inflammation, inflammatory mediators, and not so much, they are not considered immune suppressants. So it would not be indicated in a case like this where you have an immune-mediated type of condition to use a non-steroidal anti-inflammatory drug, because you wouldn't be suppressing the cells. Okay, now continuing on with our Pac-Man approach and with the general decision that was made for using glucocorticoids at the beginning, let's talk about how we would administer glucocorticoids. What is their absorption, administration, and what are their adverse effects? We've alluded to some already. Well, these are very lipophilic. They're excellent, well absorbed by the oral route, so that's good. Makes it easy to give. And we give dosages that are considered to be anti-inflammatory relatively inexpensively. They can be given twice a day. Most owners can keep up with this. The adverse effects, we talked about some of the metabolic effects that basically can drive glucose up in an animal that is particularly prone towards diabetes. But the other adverse effects are that you're suppressing the immune system, and so you may have a greater propensity towards other infectious diseases. So we also finish our Pac-Man with N, and that is we want to we want to monitor the animal. An example of monitoring for glucocorticoids would be looking at the urinalysis periodically, because about 25 or 40% of dogs with glucocorticoids treatments without any symptoms for the urinary tract can have a subclinical urinary tract infection. Okay, going back to our relevant clinical questions, we've already ticked off that effective treatment. We decided on what treatment to go with. We've decided even on the dosage. And we've talked about side effects, but we want to go a little more detail into the side effects and what other types of treatment one might use to avoid such adverse effects. So we're going to delve a little bit further into the side effect and adverse effect side of things now. So that sends us back to the literature, and we did a search here and find, I'm going to label this as I go through it again. Remember I mentioned the urinary tract, propensity for urinary tract infections in dogs with glucocorticoids. We found a 2005 paper which shows the frequency of the urinary tract infection in dogs with pruritic disorders receiving long-term glucocorticoid treatment. Well, that's very relevant to this dog right here. We found another one of a 6-year study of higher doses of a different kind of glucocorticoid leading in animals that were on treatment for intervertebral disc disease. This may or may not be as relevant because of its a higher dose treatment. This is so let's start with starring this first one. This one, the second one we won't star. We'll kind of keep it in mind. The third one, absence of urinary tract infection in dogs with experimentally induced hyperadrenocorticism. Well, this one is very interesting, but it's an experimental model, and it does say that not every animal will get a urinary tract infection, or that maybe there's some other factors going on when one controls everything in a laboratory environment. But this one, we'll sort of plus minus this one because that study is not in patients. The fourth one is about the propensity of certain animals to become diabetic. And concurrent disorders include hyperadrenocorticism, glucocorticoid administration, etc. We have another one on steroids and cardiac output, and bacteremia. That's kind of maybe interesting. We have a review article that's now 30 years old, use of antimicrobial drugs to prevent infections, and whether that's relevant for patients in steroids. We also have another one on prescribing antimicrobial drugs for dogs and a study of antimicrobial resistance. And I'm going to go through why I've listed these antimicrobial papers, because the owner had asked a question, which we'll talk about in a minute. So let's first talk about the Torres paper from 2005. The one that really kind of models a really good model of the case that we're treating. They had 127 dogs treated with glucocorticoids for over 6 months, so this is quite a long time. And they did it as a retrospective study, so that maybe not as well controlled as you'd like. But they found that 18% of these dogs had a positive culture, whereas none of the control animals had a positive culture. 25% of the dogs, the positive culture was despite the fact that many of them were on antimicrobial. So glucocorticoids lead to an increased incidence of subclinical bacterial infections of the urinary tract. And so this is a very interesting study for us to keep in mind. So going a little bit in more detail, they showed that none of the dogs showed a clinical signs of urinary tract infection. They said that if there is pyuria, it correctly predicts a culture result in 90% of the cases, and that the presence of bacteriuria also predicted culture results. And so that would all lead us to think that if we did follow this animal with urinary urinalysis, and if it looked like there were white blood cells and maybe bacteria, maybe we should culture it, this would be a good thing to do. What it doesn't suggest is that we should prophylactically use an antimicrobial, and we'll get to that in a second. Unassociated with frequency of urinary tract infection were glucocorticoid type, so it didn't make any difference what type, what dosage, or the length of the treatment. Now let's take a look at that experimental study by Forrester in 2003. The details of this were that dogs were randomly assigned to either receive hydrocortisone or placebo for 49 days. They did not see any signs of hyperadrenocorticism, and they also saw no signs of urinary tract infection. So their conclusion were that if there is a connection between glucocorticoids and urinary tract infection, it wasn't so simple, and maybe there's something else going on out in the field with real cases that do develop even subclinical urinary tract infections. Now, when we were talking to the owner of this case, the question came up, well, the owner said, I've read that animals that are on glucocorticoids may develop urinary tract infection, and why don't you just routinely put them on an antibiotic? Well, we've answered some of those questions already, but we also wanted to add this one little piece, which comes from proceedings, a statement. This is basically not from a literature study or anything like that, but it's the opinion of a board-certified clinical pharmacologist that the use of antimicrobial agents in veterinary facilities may have contributed to transmission of multi-drug resistant bacteria, in this case salmonella, by lowering the infectious dose needed for ingestion to cause illness in animals and increasing the likelihood of transmission to humans. So not only is the inappropriate or overuse of an antibacterial drug leading to resistance in the animal patient, it can also lead to resistance in humans. So we have a public health reason for having better stewardship of our use of antimicrobial drugs. So putting all this together, we critically appraised the evidence we had in hand, and basically we saw there's a 25% increased risk of urinary tract infection if we put Alaska on a glucocorticoid, but we also knew that doesn't always lead to, there's a 75% risk of not having one, and so that balances out, and it's probably not worth giving antimicrobials in this situation because you have increased bacterial resistance. And again, and you lose, if you just routinely choose an antimicrobial without culture, without having something to culture in while culturing, which you clearly can't do when you're using a drug prophylactically, you're going to lead to resistance against some very important pathogenic bacteria. Okay, so how did we apply this information in this circumstance? We gave Alaska prednisolone at 15 milligrams per every 12 hours. Remember, she was a 30-kilogram dog, so that's a half a milligram per kilogram, as the literature suggested. And then after 3 weeks, when her signs started to look better, she was having less pruritus, we reduced the dose, and we'll talk about this in the context of glucocorticoids, sequentially reducing it until we could get her to every other day therapy after several weeks. We did not use a prophylactic antimicrobial drug, And what we did do was do urinalysis on her once a month. And the goal and the idea, although we never did see evidence of a urinary tract infection, the plan is if we saw white cells in the blood, in the urine, we would collect a urine sample for culture and sensitivity at that time and apply the appropriate antimicrobial therapy, but not routinely use an antimicrobial just because she's on a glucocorticoid. The evidence didn't support it. So what was the outcome? Well, her pruritus and lesions resolved after a month of therapy. Glucocorticoids were tapered after, as we pointed out, after recovery was well underway. Side effects included polyuria and polydipsia. She had to take the owner had to take the dog out more often. There was no evidence of urinary tract infection in Alaska. And the plan is to, if she rebounds from this, would be to add the omega-3 fatty acid, 3,6 fatty acids to the diet. And that's sort of plan B if she relapses after weaning her off glucocorticoids. And if that doesn't work, to add the more potent immunosuppressant cyclosporin as basically a plan C. So in summary of our discussion of evidence-based medicine, I want to remind you most drugs we use in small animal practice are used off-label without prior regulatory review. That makes it even more important that you become a good comparative pharmacologist. That responsibility to become a good comparative pharmacologist is in your hands because you were given through the laws, the AMDUCA law, the Animal Medicinal Drug Use Clarification Act, you're given the wherewithal to make these types of calls in non-food animals. You need to understand, as a result, what the best evidence is in order to make these decisions and interact with your clients in an appropriate manner, engaging them in sort of that application phase of the evidence-based therapy. So the structured approach to therapeutic decisions, like using Pac-Man, like using the evidence pyramid, and these various checklists for looking at literature, can help you to apply evidence-based medicine, evidence-based therapy to the benefit of your patients. So if you have any questions or comments, Alaska and I invite you to pose those questions in the message boards in the course area. And we also would ask that you think about what we said about using evidence-based therapy. How easy would it be to do? How much have you seen it already? When do you think it's being applied? These are all things that anybody who's been in a practice should be able to give us comments about, and we'd like to talk about it because this is not pie in the sky. We are dealing with some really important issues, and we're trying to help you structure your response to therapy based upon the problems that an animal presents to you.